Bismillah ar-Rahman ar-Rahim. Our lecture on the valve disease. The valve abnormality can be congenital or acquired and can be manifested in form either stenosis or regurgitation. Stenosis means failure of the valve to open completely, so there is impairing in the forward blood flow, and this is mostly our chronic process. Regurgitation or insufficiency mean failure of the valve to close completely, so allowing reverse blood flow. The disorder of the valve, stenosis and regurgitation can be mixed or pure, can be in the same valve or in the combined, isolated or combined with other valves. There is a term for the functional regurgitation. Functional regurgitation means dilatation of the ventricle can cause the papillary muscle to be pulled down and outward, preventing co-optation of the mitral or tricuspid valves. So, dilatation of aorta or pulmonary arteries cause pulling of the valve commissures, so preventing complete closure. This results in the functional regurgitation. Abnormal blood flow through the diseased valve typically produced abnormal heart sound named as murmur. So murmur is the abnormal heart sound that results from the abnormal blood flow through the damaged or diseased valve. The most common abnormality are acquired stenosis of the mitral and the aortic valve, and the stenosis is almost always due to the primary cusp abnormality, and it's always a chronic process, while the regurgitation is either due to the cusp abnormality or disease of the supporting structure like the papillary muscle or chordae tendineae, and can be acute or chronic, in contrast to the stenosis that usually is a chronic matter. The outcome of the valve disease depending on the valve that involved and the degree of impairment, and the tempo of its development, that to say the time of the development of the damage, and the rate and quality of compensatory mechanism that can be seen. Rheumatic fever and rheumatic heart disease. Rheumatic fever is an acute immunological mediated multisystemic inflammatory disease that occurs a few weeks after the episodes of the group A beta hemolytic streptococcal pharyngitis. It can also rarely occur with the streptococcal infection of the other side, like the skin. Acute rheumatic fever and the chronic rheumatic fever. The acute rheumatic fever characterized by the pancarditis. Pancarditis means inflammation of the valve, which are represent the endocardium, myocardium, and pericardium. The clinical pictures of the rheumatic fever characterized by the fever, migratory polyarthritis, subcutaneous nodule, erythema marginatum of the skin, and Sydenham chorea. The most important effect of rheumatic fever is the involvement of the valves leading to the chronic rheumatic heart disease, that characterized by the diffuse and dense scarring of the valves, resulting in the permanent damage or dysfunction, with the mitral stenosis being the most common type of the chronic sequelae of the chronic heart disease, rheumatic heart disease. Regarding the etiology of the rheumatic fever, as we said, is immune reaction secondary to the strep infection, and the antibody that are formed against the streptococcal antigen cross-react with the tissue antigen, including the cardiac antigen, so that is immunological complication of the bacterial infection. The lesion in the rheumatic fever is sterile, that to say the process is the immune mediated, is not related primarily to the bacterial infection itself, but is considered as the sequelae of the immune reaction toward this bacteria. The rheumatic fever is acute, characterized by the acute and recurrent attacks, pharyngitis after about 5 weeks. Evidence of the recent strep infection is essential for documentation for the rheumatic fever. They show that the proper treatment of pharyngitis in the last decades associated with decline in the incidence of rheumatic fever. The cross-reaction demonstrated between the component of the streptococcal infection and the cardiac tissue that are supplied for or exposed to the antigen. Regarding the morphology of rheumatic fever, the pathognomonic lesion is a disseminated inflammatory foci in the myocardium known as Aschoff bodies distributed within the interstitial connective tissue. So that the Aschoff bodies are the main characteristic features of the rheumatic fever and are granuloma of buccal form. That to say, Aschoff bodies is a granulomatous lesion of buccal forms composed of the focus of swollen eosinophilic collagen that are represent degenerated necrotizing extracellular collagen surrounded by the collection of the lymphocyte, macrophage, plasma cell, and modified histiocyte known as anisocell. Anisocell with the large amount of cytoplasm, central nucleus, and prominent nucleolus, giving an owl-eyed appearance, may become multinucleated, forming an Aschoff giant cells. So, typically Aschoff nodules seen in the myocardium, and their eventual fate is the fibrosis. And this is the picture for the necrotic eosinophilic collagen surrounded by the histiocyte and granulomatous inflammation that are represent the center of the Aschoff nodules that compose of the collection of the histiocyte, sometimes forming the giant cell, multinucleated giant cells, and anisocell. This is the anisocell and forming Aschoff nodule, collection of the Aschoff nodule in the myocardium that are represent the diagnostic feature for the rheumatic fever. So the myocardium showing scattered Aschoff bodies in the interstitial connective tissue close to the intramyocardial blood vessels. The fate of this Aschoff nodule are sometimes no functional effect. That to say, the fate when the fate is resolution will result in the no functional effect. In the fatal cases, during the acute stage, the heart is dilated and soft and flabby, and the endocardium, both valvular and mural, can be giving the appearance of a small nodular or warty vegetation. And this vegetation, warty appearance, composed of platelet and fibrin along the line of the closure of the valve cusp, chorda tendini, and the mural endocardium, and giving the appearance of the verrucous endocarditis. That to say, because of the verrucous appearance of the vegetation that are present at the site of the close of the valve. The valve involvement results in the fibrinoid necrosis along the line of the closure, forming about 1 to 2 millimeter vegetation that have little effect on the cardiac function with no functional effect. These irregular vegetation, warty projection that are arise from the precipitation of the fibrin at the site of erosion of the valve caused by the underlying inflammation and collagen degeneration, and healing with minimal fibrosis or leading to the valve deformity. So that there's a sequelae of events that result from the necrosis of the collagen and the development of vegetation and even fibrosis, and result in the valve deformity is the end sequelae of the rheumatic fever. This is the gross appearance for the vegetation that are seen at the site of the valve. This is the vegetation that are composed of the fibrin and necrotic material, clot, bloody clot, and fibrinous material. Regarding the acute rheumatic heart disease, acute rheumatic heart fever involving the entire heart, pancreatitis, that to say endocarditis, myocarditis, pericarditis, and constrictive pericarditis can be seen. The acute rheumatic heart fever heals without any sequelae in most instances. However, all those who once had rheumatic fever are at increased risk of recurrence and exacerbation of the cardiac lesion following another streptococcal infection, with the additional infection can be occur. While the chronic rheumatic carditis develop only in 1% of all the cases of the rheumatic fever. Chronic rheumatic heart disease more likely to occur in the following condition: when the first attack occur in the early childhood. With the early age of the first attack, the most likely to develop the chronic rheumatic heart disease. The initial attack, severe initial attack of the acute rheumatic fever, and the recurrent attacks of the rheumatic fever, all this will be exposed to the development of the chronic rheumatic heart disease. The most important and the most common features of the chronic rheumatic fever are seen on the valve. As we said, the valve will develop vegetation, fibrosis, deformity, and sequelae. Mitral valve most commonly involved. After that, development of both mitral and aortic combined involvement, and aortic stenosis is rarely occur. Aortic valve is rarely occur. Pulmonary and tricuspid are extremely rare to be affected. Pathologically altered valve show, that to say, the main damage of the rheumatic fever occur on the valve and showing the cusp deformity, shortening and fusion of the chorda tendineae, residual fibrinoid vegetation, often become infected with bacteria. As we said, consider the focus for the infection. Superimposed infection may cause ulceration of the cusp, perforation of the valve, and rupture of the chorda tendineae can be seen. So that is the main sequelae of the valve. Another topic is the calcified aortic stenosis. Calcified is dystrophic calcification in the degenerated aortic valve leading to the narrowing of the orifice. As you know, calcification, there are two types, either metastatic or dystrophic. And here we are dealing with the aortic valve that showing degenerative change with the time. And this degenerative change are considered the predisposing factor for the development of the calcification and forming dystrophic calcification in the valve. So this calcified aortic stenosis is considered part of the normal aging process. The congenital bicuspid aortic valve predisposed to the aerial development, while the valve is the tricuspid, but sometime the aortic valve will be congenitally bicuspid, and this type of the congenital anomaly in the valve are predisposed for the earlier development of dystrophic calcification. This calcified dystrophic calcification in the valve will lead to the left ventricular hypertrophy due to left ventricular straining, trying to overcome the valve orifice, narrowing the underlying hypertrophy. That to say, with the compression or the obliteration in the lumen of the outflow of the valve, this will result in the hypertrophy of the left ventricle. Clinically, patient will have angina, syncope, or sudden death due to the arrhythmias. Clinical examination of the aortic stenosis reveals high-pitched systolic murmur. That to say, the irregular sound that are developed will be during the systolic phase of the heart, so that is a systolic murmur. Mitral valve prolapse or regurgitation. This type of the abnormality developed as a result of the accumulation of loose ground substance in the valve, causing it to become floppy and incompetent in the systole. This condition is common cardiac condition in about 50% in the population, mainly in the female. May complicate certain connective tissue disorders like the Marfan syndrome, characterized by the regurgitation of blood from the left ventricle to the left atria during the systole. Usually during the systole, the mitral valve should be closed completely, but in the regurg, some of the defects that occur that allowing the blood to push from the left ventricle to the atrium during the systole, causing dilatation and hypertrophy of the left ventricle and left atrium, and right ventricle through the back pressure on the lung and right ventricle. So that there is a disorder that occurs in the left ventricle and atria, in addition to the lung and background to the right ventricle. Most patients are asymptomatic, but are more liable to development of infective endocarditis, mitral incompetence, thromboembolism, and arrhythmias that's seen as complication of the mitral valve prolapse. Infective endocarditis. Infection of the cardiac valve or mural endocardium resulting in the formation of vegetation. That to say, similar to that vegetation seen in the rheumatic fever, represent as adherent mass of thrombotic debris and microorganisms. While that vegetation in the rheumatic fever was sterile, now the vegetation are septic. That to say, associated with the microorganism. 30% with no any obvious predisposing factor, but mostly 70% cause cases there is one of the predisposing factor for the development of infective endocarditis, which are including the chronic rheumatic fever, congenital heart disease, calcified aortic stenosis, and mitral valve prolapse. Infective endocarditis occur when the organisms are implanted on the endocardium during the episodes of bacteremia, as in the case of intravenous drug abuser, like those with the Staphylococcus aureus, focus of infection elsewhere, like the gram-negative or gram-positive or fungi, dental or other surgical procedures, and prostatic valve. All this considered as the predisposing factor for the development of bacteremia that allow the deposition of the microorganism on the endocardium. The types of infective endocarditis traditionally it has been classified on the clinical ground into the acute and subacute form, with the express the severity of the disease. That to say, with the acute endocarditis, there is a destructive infection of the previously normal valve. That to say, those patients will develop destructive damage for the normal valve by the highly virulent organism that lead to the death of the more than 50% of the patient, where the symptoms develop much faster. In contrast to the subacute endocarditis, there is infection of previously abnormal valve. That to say, in contrast to the normal valve that's seen in the acute endocarditis. But the difference is that the microorganism will be low virulent microorganism in contrast to the highly virulent organism that causing the acute endocarditis. Most patients are recovered, while the 50% of the patient in the acute carditis will pass to the death. Most patients with the subacute endocarditis will be recovered with antibiotics. The lesion tend to be less destructive. There are no strict criteria for separating clinically, but there is underlying complication will develop and pass. There are three criteria of patients with infective endocarditis: either those with the damaged valve or abnormal hemodynamic state. The organism mostly are strep viridans, Staph aureus, and other commensal in the oral cavity. Those with the prostatic heart valve, the organism like strep epidermidis and gram-negative bacilli and fungi, and intravenous drug abuser organism mainly Staph aureus. Regarding the complication of the infective endocarditis, either there is direct injury to the valve leading to the insufficiency of the valve leading to the congestive heart failure due to the invasion of the bacteria to the valve and to the valve base. That to say, there is a cause perforation and rupture of the chorda tendini, and healing stage may end with fibrosis and calcification of cusp. The second is the myocardial abscess, where there is a ring abscess formed at the base of the cusp that may be ruptured. The third is the extension of the infection to the root of aortic, where they are named as mycotic aneurysm. Mycotic not mean a fungal hair, it means extension of the infection that are usually bacterial toward the aorta and causing the aneurysm. The fourth complication are embolic phenomena, where there is fragmentation of vegetation may end with the ischemic infarction, else distal. And fifth is the renal complication, while the antigen-antibody complex may released from the infected endocardial vegetation and circulate in the blood and deposit in the wall of the glomeruli and small blood vessels, resulting in the focal and diffuse glomerulonephritis, and renal infarction can be a result. Another type of the endocarditis that are non-bacterial, thrombotic endocarditis, that result from the deposition of the sterile vegetation resembling thrombi, composed of fibrin, RBC, and platelet on the cardiac valve. The exact pathogenesis is unknown, but seems to form at the site of immune injury of the endothelium, normally occurred and repaired. That to say, that occur can be seen and repaired of the endocardium. Usually seen in the debilitating patient, those debilitating like those with advanced cancer, where the normal repair mechanism are defective, and the endothelium defect is filled with the platelet and fibrin. The hypercoagulatable state, when the state of the blood associated with hypercoagulation, the activation of blood coagulation due to the hypercoagulable state, as with the mucinous adenocarcinoma of the pancreas, acute promyelocytic leukemia, and extensive burn or sepsis. All these three conditions associated with increased coagulation state of the blood, and so that the main problem is the thromboembolism or infection, so predisposed to the infective endocarditis, and large vegetation may be fragmented and give rise to the emboli. So it's considered as non-bacterial thrombotic endocarditis when there's thrombus can be fragmented and forming emboli. The last type of the endocarditis named as Liebman-Sack endocarditis. Liebman-Sack endocarditis represent a small sterile vegetation on the mitral and tricuspid valve in the some patients with those with the systemic lupus erythematosus. Those type of the endocarditis associated with the presence of antiphospholipid antibodies present in the form of multiple small wart-like excrescence or vegetation on the mitral and tricuspid valve, and this vegetation results from the immune complex mediated injury of the valvular endocardium and followed by the thrombus formation. So that vegetation consisting of fine granular eosinophilic material with the fibrinoid necrosis of the valve may lead to the valve incompetence, and vegetation can be identified in the living patient by the echocardiograph, but these lesions are clinically of little significance.